Hi, everyone. Thank you so much for being on time or early. We're going to get started. So thank you so much for joining us today. If you are here for the MOUD training and best practices, you're in the right spot. If you aren't here for that, then you might be in the wrong spot. So thank you so much. We'll get started and I'll hand things over to HCA and Dr. Fatinos to intro us in. So thank you so much.
Hello. I guess I'm starting this off. Good morning, everyone. Are we not showing ourselves on camera? We're all being mysterious today, I take it.
We can be on camera, yeah. And apologies to attendees. Yeah, we didn't get a waiting room set up, so we're strategizing on the spot. So yeah, happy to turn cameras on. I think we have a slideshow we're gonna have going too.
Yeah, I mean, I'm happy while I'm talking to be on camera. I don't need to be all the time, so whatever works is fine, and I'm happy to start without that.
Let's do cameras on, yeah. And then just confirming, Jess, our slides working right?
I believe things should be good. I think Charissa will be sharing slides, and then I'll be switching over and sharing slides.
Perfect, sounds great.
I will not be sharing slides because but I will be chatting. So would you like us to go ahead and get started?
Yeah, let's get started. Thank you so much.
Great. Well, welcome everyone. And you will just hear a voice. So my name is Charissa Fatinos. Jessica asked me to start off the discussion this morning, which I hope is at the end what it will be, and really with the focus of how can we better support our patients, clients in their recovery while they are in transition or in places that to date really haven't supported the use of medications for opiate use disorder, whether that be inpatient residential substance use disorder treatment, mental health inpatient facilities, skilled nursing facilities, assisted living facilities, adult family homes. I think that we're at the point, separate from the law that was passed a couple years ago, that really we have to figure out how we can best support agencies in supporting what is the treatment of choice for people with opiate use disorder. I think definitive studies have been, I think the evidence is very, very clear that the treatment for opiate use disorder is opiate agonist therapy. Whether that's methadone or buprenorphine doesn't really matter. The evidence for the use of naltrexone as a treatment is much less compelling. It may help reduce use rates, but it doesn't seem, or there's not evidence yet to support it reduces mortality rates. So first message, opiate agonist treatment is the evidence-based treatment of choice for opiate use disorder. That said, there remain a lot of challenges, particularly among agencies that are not familiar with its use. Agencies, for instance, substance use disorder agencies whose sort of historical focus has been on abstinence only, and somehow in that discussion of abstinence, the use of medication replacement therapy was included as part of that abstinence. So I think there are varying attitudes, as you all know, around medications for opiate use disorder. I think this is a timely discussion in large part because fentanyl has greatly changed the landscape of how we think about and how we treat opiate use disorder. In the past, people could successfully, go through a period of withdrawal from heroin. They would be miserable, but often they could be successful in being abstinent for a while, but the relapse rates were incredibly high. That's not necessarily the case with fentanyl. As you're all aware, fentanyl is extremely potent. The number of times someone has to use it, instead of, people who are using heroin regularly might use 3-4 times a day. People who are using fentanyl, particularly smoking it, are using 20 to 30 times a day. So their entire day is spent trying not to be in withdrawal. And the withdrawal is much worse and it's prolonged. So the days in which we think that either a medication taper for someone using fentanyl regularly is going to be effective, or just them tapering without any supports to a place of abstinence, that's just not realistic anymore. People are not going to be successful. So I think that sort of the second message is we have to think really differently in the world of fentanyl, just because the way the pharmacokinetics work, it's released very slowly from the body, and that creates a challenge in starting people on opiate replacement therapy if they are using fentanyl. And that I was just reading something yesterday where one provider's approach is, and this is in people who are pregnant, but one provider's approach is to start with 64 milligrams of buprenorphine. The FDA approved upper dose is 24 milligrams. They start with 64 milligrams of buprenorphine to completely flood the receptors, knock off any remaining fentanyl, and then they start to taper down from there. People are using IV Dilaudid to transition people. People are using IV ketamine to transition people from fentanyl to opiate replacement therapy. So this is a completely different landscape than we've dealt with before. Withdrawal management services make no sense because people aren't going to be successful. People are already feel badly enough for, sort of where their condition has taken them. And I don't think we're serving folks well if we try to continue to support treatments that we know are going to be really hard for them to be successful in. That doesn't boost confidence and support recovery. I would say that undermines it. So I think that, that just in my observations the last few months is that we have to think differently about how we approach folks. And we've heard from the treatment providers themselves, all these people on fentanyl, they don't stay in treatment. That's because they are in fluid withdrawal or feel miserable and either are on a medication at a suboptimal dose or aren't on any medication at all, and they're not going to stay in treatment. So I think, how do we work together to help support agencies in getting to that place where they're able to support people on medication, recognizing that arbitrary limits are not going to be helpful. I know some facilities have been great at saying, we'll accept people, but we have to set a limit of 30 milligrams of methadone. Again, in the old days, maybe that would work when there was heroin. I'm hearing colleagues in different states who, their patients are on 200 milligrams of methadone. That used to be a pretty unheard of dose, not anymore. So I think the thinking that, there's a limit to which we'll accept people and not everybody's going to have a different limit at which they're comfortable, not in withdrawal and their cravings reduced. So I think we have to, both in our minds, be more flexible and help agencies understand that arbitrary cutoff points are not going to be helpful for folks because they're going to be unsuccessful, and that's not going to contribute to a successful, residential stay or entry into recovery. So I think that that's an important thing. So how do we, the other piece is switching medications. I think that, again, maybe in the past, if someone was on a very low dose of methadone, and when I was transitioning people from methadone to buprenorphine, 40 was pushing it. If 30, maybe you can transition people to bup. But if you're on a higher dose of methadone, it's not easy. So I think that the thinking that, agencies are like, well, we do bup, but we don't do methadone. Pharmacologically, that's not very sound. And with the doses of methadone that people are needing to use now, again, that's not going to be successful, which both frustrates the treatment agency, but more importantly, sets the patient up for failure when they're already feeling terrible. So I think thinking about, using pharmacology and what we're learning about how fentanyl works and it affects folks, we have to help get residential treatment providers of all types to that point. I think the other thing, Jessica asked me to sort of comment on, if we had an ideal pathway for folks who are struggling with opiate use disorder, or really any substance use disorder, but I use opiate use disorder because that's, certainly what we're dealing with along with fentanyl, but along with stimulants. But in an ideal world, we would approach the treatment of someone struggling with a substance use disorder as we would any other chronic condition with shared decision making. That person would, in an ideal world, say, I can't continue to live like this. I'm, not seeing my family. I'm not meeting my obligations. I hate being sick all the time, or when I'm not sick, not motivated to do anything. I don't want to live like this anymore. In an ideal world, the discussion would be, okay, well, thank you for coming in. Here are your options. Here are the different ways in which you have to choose how you would best address your substance use disorder, in this case, opiate use disorder. One includes medication. If that person's using fentanyl, they would be given information about that. We are pretty certain right now medications is that, that abstinence isn't the best policy, at least initially. And so we would give a person choice. There's residential treatment, there's outpatient treatment. You might from an ASAM level tier to a residential level of care, but you have 2 kids at home. That's not feasible for you. What can we do? What makes sense to you in your life right now to make you be successful in your recovery journey, right? Those will be the conversations we have. Our system isn't set up like that, but perhaps, we can move to that. So in the absence of that, how do we collectively support folks so that they can be stabilized and be successful? And I'm not even talking about the risk of overdose death. As you all know, the risk of overdose related death with fentanyl is high. Tolerance goes away fairly quickly. And so this is really, I think, a time of crisis from a number of people involved perspective, but also because fentanyl is so potent, it's touching people that we would never think it would touch before. We had a employee of the healthcare authority who lost their adult daughter not too long ago, inadvertently from, a pill that was laced with fentanyl. So I suspect we all know people who have lost loved ones. So I think this is really a time to continue to have conversations to folks about, one, we have to think beyond what we've always done. 2, this is about the people. And 3, we can't help people if we can't keep them alive. So how does that translate to what we're talking about today? I think there are good examples of folks who have transitioned or sort of embraced the thought that medication is one of the tools, and in the case of opiate use disorder, probably the first and primary tool for stabilization for folks. And yes, people likely need other psychological supports, whether that's best met through residential traditional substance use disorder treatment or through therapy for their PTSD or their childhood trauma or their history of sexual abuse, right? There are multiple paths. So how do we help people find their path and support them? So I think I don't want to ramble on a lot more. I don't think I've said anything controversial, but I do think from the healthcare authority perspective, we expect that people who are on a dose of methadone or on a dose of buprenorphine, who may also have a history of alcohol use disorder, who relapse, or who may also be struggling with, substance use, with stimulant use disorder, that whatever dose they're being prescribed by their provider when they enter treatment is the dose they are on when they are in treatment. And that if that person has not had access to a provider and they're not on medication for opiate use disorder and they want to be, that agency needs to help facilitate them accessing that medication. Now, like with fentanyl, that's going to be trickier because they're going to have a provider who's fairly used to transitioning people or starting people on fentanyl, on whatever it may be, in this case, buprenorphine, because they're not methadone clinics. So I think it complicates the person who's not on medication first. But I think our expectation is that folks, like any other med they're prescribed, they continue it, they stay on it, they're supported in its use, and they receive the benefits of that treatment program. So that's the sort of substance use disorder program perspective. Jessica has been working tirelessly along with some other folks on getting skilled nursing facilities to the point where they will accept people on methadone, where they will accept people on buprenorphine. I don't think that's the purpose of this discussion, but that may be a future webinar. I'm not sure what Jessica has in mind, but happy to talk about the efforts that we're doing there and the journey we've been on trying to do that. I will say that I was on a call before this with the Department of Corrections. They are having an overdose about once a week, whether it be in their community corrections setting or in their facilities. I talked to the Director of Aging and Long-Term Services last week. Every week, every other week, they're having an overdose death in someone in an assisted living facility or an adult family home. So we have to figure out how to better manage and support folks a lot of times who are, using stuff that they don't think is fentanyl, but is. So this is the first, I think, of an ongoing conversation, but I want to stop there and make sure that I was able to address the pieces that Jessica was hoping I would.
Thank you so much, Dr. Patinos. So good morning, everyone. I am Jessica Bloth. I am our Washington State Opiate Treatment Authority. And, another purpose and what we'll be going into with this webinar today is exactly what Dr. Patinos referenced earlier. We have had a number of behavioral health agencies that have been able to actually engage with culture change within their own agency, need to help educate and update staff on clinical best practices, and all of the different ways agencies have had to transition to learn to coordinate care in order to allow these patients who are taking medications to treat opiate use disorder to be able to continue their medications when they're going into SUD residential treatment facilities. So I'm going to begin sharing my screen, but I'll be turning the conversation over to our partners at the managed care organizations to introduce two guest speakers today that are coming from, settings that are already behavioral health agencies and that represent SUD residential treatment sites that have already begun engaging in this work to share their experiences with you all today. And I apologize. I believe it is not sharing the correct screen. So if you give me just one moment. Let's try this. All right, here we go. So at this point, I'll turn it over to folks, I believe from Melina, who are going to introduce some folks from Kitsap Recovery.
Yes, thanks, Dr. Patinos and Jessica. Really appreciate your opening remarks. And I'm Tori Gildred from Molina. I'm actually an LSSW and substance use disorder professional myself, and I really appreciate this conversation because now more than ever we have a call to action to really make sure that we're delivering best practices and we're ensuring that we're really treating and supporting our members and our the populations that really could benefit from best practices and medications for opioid use disorder. So first off is our provider partners from Kitsap Recovery Center, Keith Winfield and Brian Boyer, and just want to say really appreciate, we spoke with them earlier this year and had a great conversation, really highlighting a lot of the elements that Jessica and Dr. Patinos mentioned. And I think it's really important to hear from peers, especially in the SUD world, who have done this work and have engaged in some of the change management in their agency. So I'm going to hand it off to Keith and Brian. Thank you so much.
Good morning, and thank you for having us. And I definitely, Dr. Fontinos said some things that were really important, and we were in that bucket of kind of resistance from an SUD perspective years back, but we have done some hard work to make some changes. So let me tell you what we do at KRC. We're withdrawal management at 3.2 level, which is clinically managed. So we're not medically managed in our detox. And we're 3.5 for inpatient, not co-occurring. And we do have 2.1 and 1.0. And so what we've had to do as an SUD provider is leverage a lot of our partners in the community. So we're not medical detox, so we're not going to prescribe you Suboxone when you come in for detox. However, we partnered with a local community clinic, a PCHS, and Brian has set this all up. He's able to get folks the same day in to see the doctor and get them started and inducted on to methadone. Onto Suboxone. Regarding methadone, we've set up a partnership with the clinic that's in our community, and so they will get a hold of us. They have a client that's on methadone, and we will support them in through residential treatment while they're here. We have a strong belief, and Brian can especially speak to this. We've seen so many people where the cravings overtake them, and if you can't offer them this relief in this setting, they leave, and then we lose them, and that happens quite often. And I think the doctor was really focused on that, and it's a very important topic. There's been a lot of resistance, and definitely a lot of resistance to methadone, and I think that that's ill-served in our SUD communities. I understand that there's this abstinence-only model, and there's some resistance to that, and we struggled with that too. But we've started to see the better outcomes that we get for our clients, and that's kind of the point. So we're able to manage starting in detox, getting them started, or they come from a clinic, a methadone clinic, and we're getting them engaged in treatment. They come with their medications. We actually go with them. We take them, we sign for them, because if a client goes ASA, we want to return the medication back to the clinic and allow them to follow up with the clinic. We also have a doctor here, like most residential facilities, not full-time, but she comes in a few times a week, and she absolutely supports MOUD. So if a patient is local, we'll get them started with the clinic. They'll have their Suboxone, methadone, or whatever they need, a Vivitrol shot, while they're engaging in treatment and the behavioral health side of things. But also, if they're from out of the area, we can get them with that clinic. What we do is we set them, our doctor will prescribe to get them inducted, and we set them up with an appointment the day they leave, typically, with an agency in their area. So that is an important key, is when they leave here, the treatment doesn't stop. So we have to set them up for success. And that means getting them on the phone and having those appointments, not just handing them a list of papers of where they can make those appointments. So if they start, let's say they're from Olympia, and we'll set them up with a clinic, they'll have an appointment, and then our doctor will get them started on the Suboxone right away. If they're local, we'll send them to a local clinic here, and we just have such a relationship with them where we can get them seen same day, and it benefits both agencies. And so that's what I'm talking about when I'm talking about leveraging. That's just kind of the way we've kind of done it, and we've done it without having a full medical staff here. Again, it's about finding partnerships in the community that'll work with you. We get medications delivered the same night that they're prescribed. We've set up partnerships with pharmacies and things like that. Brian, do you want to start adding?
Yeah. So for the withdrawal management piece, I was listening to with the fentanyl and starting on 64 milligrams. So the people that we partner with, what they do is they microdose. So about day 2, when the client's in withdrawal from fentanyl, they'll prescribe a really low dose multiple times a day to slowly start to build up. And it's been pretty successful. Most of the clients that come into withdrawal management on fentanyl that go through that process stabilize, within 5 to 7 days, and then they get up to a normal daily dose that they would be taking. So what that looks like is they normally send the 2-0.5 milligram strips, and they have to cut those into quarters. And day 1, they take 6 quarters every 2 hours apart, starting at 10 a.m. So like 10, noon, 2, 4, 6, and then 8. And then, they go to sleep. And then the next day they go up to a half of the 2-2s 6 times a day or 4 times a day. I don't know the exact dosing. They always send us with a script, but what we found is starting them on the higher dose, it sends them into precipitated withdrawal. And it makes them feel a lot worse rather than better. Where the microdosing, it's replacing what it needs to replace in small doses and not sending them into severe discomfort. But yeah, fentanyl is definitely changed.
Landscape, yeah.
Yeah, it's changed a lot.
Could I add, this is Sharice Fatinos, could I add a clarification? Brian, you make an excellent point. Most people are using the microdosing method like you described. I think there are a lot of different recipes, as it were, that people are using. There are different protocols out there. Most folks, because they are in an outpatient setting, have to do that microdosing because they're not going to have people come back every day. I use the 64 milligrams as an example. On the listserv, they were talking about in-office IV ketamine as a transition instead of the, small doses of buprenorphine. So people are trying all kinds of things. There are people using hydromorphone, people using, in Canada, they're using pharmaceutical heroin type medication. So I think we don't yet know the best answer, but the most standard practice is exactly what Brian's saying: microdosing with a transition slowly while you taper down the fentanyl, add more buprenorphine. So that's what you'll see standardly in practice. I'm not trying to suggest overload people, but this was in an inpatient setting where they could just massively dose and then block that person's withdrawal, but you're not going to do that in an outpatient setting. So thanks for bringing that up, Brian.
Yeah, you're welcome. And I mean, the important part is the partnership. So like, we're non-medical detox, so we don't have doctors, we don't have nurses. But that relationship that we have with our local community health and the BAT phone number. So like, I have an inside line where I call and it goes directly to a person. I don't have no phone tree, anything like that. If I got somebody in detox that's in withdrawal, as long as I can call them early enough in the morning, they will get that person in and seen that day and started on medication to help them get through the withdrawal process. So our withdrawal is inpatient setting, but I mean, obviously we'll bring the client to the clinic to get started. Methadone is relatively new for our agency. I feel like there's always been like a stigma out there against methadone. Like they're just, yeah. But what I know is that if the clients are on methadone and they're taking it as prescribed and they're doing what they're supposed to do, people are really successful in either model, the methadone or the Suboxone. So. Hello?
I think that's all we might have. Any questions about how we do it? I know that most of the agencies, SUD agencies, are typically 3.2. There's a lot more of that than medical detox, and 3.5 or 3. Rather than hospital-based. But you're able to develop these. I think there's community health agencies in the community that would welcome partnerships, and that's how we've had to do it, and it's been extremely successful for us. It's just a matter of taking the time to set those up. And one of the benefits for the partnership is how it benefits PCH is they have grant money to do MOUD services, and so they need clientele. So we're kind of flooding them with that clientele. And we've developed the partnership that they've gotten away from the hub and spoke model and no longer, but it's so valuable to them and so valuable to us that we're able to continue on with that partnership. And I know there might, there's some settings where the doctor maybe does telework and is not, but our doctor is really good about making sure that anybody who wants it, we just don't want to put any more barriers in the way for patients that are trying to get better. And by taking away medications that are helpful, that in my mind is a barrier to them getting their recovery.
Well, I appreciate so much everyone who's spoken from Kitsap. I think we are going to have a Q&A time later in the hour, but I think at this point we can also transition. We have an additional group of or provider from Pioneer Human Services, and I will be turning this over to, I believe, Terry Lee to introduce our next speaker.
Yes, thanks, Jessica. And thank you for all the attendees for coming for this discussion, and also to the presenters for also collaborating around this discussion. I'm the Community Health Plan of Washington Senior Behavioral Health Director, and also a boarded in addiction medicine. It's my pleasure to introduce Roel De La Cruz from Pioneer Center North. He is the director, the program director of Pioneer Center North, and a substance use disorder professional. So as we were planning this, we thought that we thought of the very active and robust MOUD program that Pioneer Center North provides, and thought it'd be good to share like some of the things that they're doing just to stimulate ideas for everyone. With that, I'll turn it over to Roel.
Hi, thank you. It's my name's Roel. I'm the director of PCN. So I think this is a really good discussion that we're all having around opiates and fentanyl. So our program, Pioneer Center North, we recently introduced the opioid use disorder residential program sometime around 2018, 2019. And so we created this program in partnership with healthcare authorities and MCOs to support individuals that have primary substance use of opiates. And so which it has been a pretty effective model. So we have programming specific to those individuals, and we do take methadone into our facility. But like what Keith said, partnering with the community is huge, because we do partner with our local methadone clinic, which is the Dwalich in Anacortes. So we take our clients there for methadone dosing 5 days a week, Monday through Friday. And so for weekends and holidays, we'll take back the carries. And so we'll dispense those medications here. So it's been really helpful for those individuals that need methadone. So I'm looking at my list right now, currently today, for clients that are currently at PCN. I have 7 clients on methadone and 24 clients on Suboxone or buprenorphine, what have you. So we do dose the clients here. So if the clients come in and they haven't been on their Suboxone, our ARNPs will meet with them at intake, and they will start to prescribe them Suboxone. So whether if they meet the criteria for that, or they're starting to have withdrawal symptoms, our ARNPs will get on it, prescribe them the medications that they need, and they'll continuously follow that client until they discharge. So our OUD program can either be 3.5 or 3.3, depending on the client need. So they will follow them and meet with them periodically, and those clients will also work with our nurse supervisor or a healthcare staff just to monitor their symptoms, and then we'll get them scheduled for clinic on an as needed basis to adjust the dosing. So we've been doing that for quite some time. I believe Suboxone had been part of PCN probably around the time Suboxone came out, where you had to have a authorization with a primary care with your doctor, and then having an SUDP sign Suboxone. So way back when, so we've had Suboxone in this facility for quite some time. So we've been comfortable with having Suboxone for our patients. And I think the success rate is pretty good for our clients. But of course, there's sometimes some clients would like more than the 24 milligrams, because that's the maximum dose that our provider is prescribing right now. And so I don't know. I think our providers should be part of this discussion, just because so she can learn more about other models and learning from the doctors that are using Suboxone. And I think this discussion is really great. We also do have a co-occurring program, and so within that co-occurring program, we also have patients that are on Suboxone or methadone. So same principle. We'll continue them here. We also work with our local detox facilities. So if the detox facility had started them up on on Suboxone, then we'll definitely continue that for our clients. And so it just so happens in the North Sound region, we have Skagit Community Detox, Whatcom Community Detox, which is also part of Pioneer Human Services. And the same ARNPs that are working at Pioneer Center North are also the ARNPs that work for these programs. So they will induct Suboxone at those clinics, along with Etuha, which is our stabilization facility. And the North Sound Behavioral Health Treatment Center in Everett has the same model as Pioneer Center North, with opioid use disorders and core and the co-occurring program at level 3.3. Their program there is at a 3.3 level of care. So yeah, so I think we've been doing a pretty good job partnering with our communities. And I know in the beginning when we started increasing the Suboxone with a lot of clients, we got a lot of pushback from our staff. But ever since then, you know, with the whole fentanyl crisis that's going on right now, a lot of the staff members that were biased around MUT, they really changed their thought process around it now, so which is a good thing. And that's all I have.
Well, I want to thank you, Raul, for being here today and kind of sharing the experiences of Pioneer Center North and your staff. At this point, this is Jessica Bloss, the State Opioid Treatment Authority. I'm going to take back over for just a few minutes because as we're talking about these, you may be having a number of questions that are coming to mind. You might be wondering, what are all the variety of ways that, you know, we as a RTF could offer buprenorphine initiation or continuation to patients in your facility? What are the variety of ways that you as a RTF could offer methadone initiation and continuation? You might be wondering, are there materials out there that can help us inform our staff about how to have these conversations with patients about shared clinical decision-making, specifically about informing patients about medication options that could be available to help them? You might be asking, you know, well, how do I find these community partners? I know that has been highlighted by our speakers. Where can we find the opioid treatment programs in office-based settings? Is there anyone out there who can help get us in contact with these providers directly to help build that connection so you can ask questions and then establish that productive working relationship? You might be wondering, well, you know, we have some prescribers on staff. What do we need to do to maybe just get our prescribers up to speed to be able to offer buprenorphine to treat opioid use disorder? Might be wondering, you know, in what ways can we use telehealth to work on these connections? You also might be thinking, gosh, you know, can we get any resources or are any resources available from Medicaid to help pay for transportation costs that go into care coordination of patients needing to go off-site to access medicines? What can we do so we can work things out so we don't necessarily have to transport patients daily? You know, a little known fact is actually for methadone clinics, the current state and federal regulations actually allow for coordination that a patient doesn't have to always go to a methadone clinic every day for dosing. We could help to have you arrange coordination to have a patient's medication only needing to be picked up once a week, twice a month, or once every 28 days. And then lastly, you might have questions just about, you know, well, what members of our RTF staff are able to help with dispensing of medication? How can these these medications be stored or inventoried on site? Really, the answer is we at Washington State are here to help you all. There are staff members at Healthcare Authority and Department of Health who will be happy to connect with you. We can provide you with a number of, again, citations relative to state and federal rules around these topics. We can give you a copy of a Q&A guidance document that answers commonly asked questions, such as all of the questions we just referenced on our previous slides. We can give you technical assistance on how to find these community partners, whether it's a methadone clinic, otherwise known as an opioid treatment program, or buprenorphine prescribers in your community. We can actually help do an e-introduction to just introduce your leadership to leadership at methadone clinics in particular, in order to help you build a new working relationships. Now, we at the state are willing to have one-on-one virtual technical assistance appointments with you and your staff to help you answer questions, so you know when you're trying to change policy and procedures to encompass these new workflows. Basically, we can help answer certain regulatory questions so you know what is possible, and you can build policy and procedures that will work well for you and your staff. So ultimately, again, here in Washington State, we sincerely are invested in, seeing our treatment system continue to evolve and being even more open and accessible to all patients. So if you have any questions at all, you can always reach out to us. I will be screen sharing some of my contact information. Again, I am our state's Opioid Treatment Authority. I will make sure I also put this information in the chat. My email address is here. I have a work cell phone that we'll be sharing. There are also staff members at the Department of Health and the Health Systems Quality Assurance who will be willing to connect with you. We know that all RTFs are licensed by the Department of Health. And again, we can help. Folks like Dan and I specifically are more than willing to connect with any one of our questions you may have. And again, there are lots of resources that we at the state can offer to help you as you navigate any changes that your organization needs to think about taking. So with some of these resources in place, I think at this point, I'm going to transition the conversation back to my colleagues at the MCOs to see if there is time and capacity to still have some element of Q&A. And then any other comments that the MCOs would like to highlight about best practices that they have seen in their provider networks around this area.
Thank you so much, Jess. Yeah, this is with Melina. And yeah, just looking through the Q&A section, please do utilize the chat, the Q&A, and please enter your questions so we can go through them in the order they were received. I do know we're going to actually start off with a question that Dr. Fatinos wants to answer live. The question about 64 milligrams of Suboxone at the start and taper down. Did I hear that right?
Yeah, I did address that because I couldn't figure out how to just type it in the chat earlier, so I apologize.
Oh, no need to apologize. I think we just forgot to click that it was answered live. So yeah, I don't see other questions. So we have this time open if anybody would like to, drop any questions down, or if anything was unclear, any thoughts, feelings, reactions. We do have one question. Thank you, Laura. Do fentanyl withdrawals look much different from oxy, heroin, etc.? So whoever would like to, field that question, just kind of addressing how they do look different, if in any ways.
I would defer to the folks working in withdrawal management facilities right now. I mean, I'm told it's worse, but I haven't cared for patients directly with it lately, so I would defer to the folks seeing people every day.
Yeah. Thank you. I see Brian typing. I'm not sure if you'd like to just answer live.
Yeah, I'll answer live. I would say they are a little more severe and a lot longer lasting. So it's still the same withdrawal symptoms as opiates, the body aches, the nausea, the vomiting, all the other stuff that goes along with that. Just the complaints are they're more severe, and they last longer than just coming off of heroin or oxys or Percocets, stuff like that.
And that makes sense because the potency is so much higher with fentanyl. So everything's kind of, the tolerance is higher, the amount that people are tolerant to is higher. And because it sort of stores in the fat as it's eliminated from the body, that adds to the duration, which is counterintuitive because fentanyl is so short acting. You would think it would clear the system quickly, but it does not, which is part of why I think folks are so challenged in trying to transition off of it onto something else.
And I would also add to that, that if we chose not to get them help on medication, they leave. The pain is so severe that it's difficult for them to manage without some sort of intervention and MAD intervention.
Yeah, thank you so much. Next question we have is Spokane Treatment Solutions only gives carries for Sundays. Just curious to hear about any assistance or any way there could be help navigating this obstacle.
Great question. And again, the slide that should be on the screen is my contact information. I am our state's Opioid Treatment Authority, and part of my authority is actually over opiate treatment programs, aka methadone clinics. So I would love to connect with any parties that might be having daily dosing or requirements to talk about bringing both parties together to see what could be possible with moving things to less frequent dosing. I do think, as all care should be individualized, there could be some reasons for some patients needing to go more frequently, but also a lot of patients likely don't have to go with that frequency. So again, I would love to connect with you offline. I would encourage you to reach out to me. I absolutely could set up a conversation with that OTP provider, your organization, and I could be there and we could have a discussion about what is possible to help make that partnership easier for all parties involved. So really looking forward to hearing from you offline. And also that offer goes out to anyone on the call who has a similar request for assistance with this topic. Thanks.
Yeah, thank you so much, Jess. And Holly did add just, when they do have when they have clients, they're taking them to multiple clinics, it becomes a huge roadblock. So I think that, that'll be great for you too, to be able to connect offline and do some problem solving. So next question is, do we have any resources for documentation specifically for time spent dissolving Suboxone? Can we bill for this time? And Leslie also showed that, she's an ARNP prescribing in inpatient SUD.
Could you repeat the question again? I'm sorry, I didn't quite catch the dissolving piece.
Yeah, the question is if they can be, if there are any resources on time spent dissolving Suboxone, and then the follow-up question is if they can be billing for that time.
So I'm not sure if Ashley is on and would be willing to, or could come off of mute to clarify. Are you asking Ashley, is there a way to bill for time that staff would observe basically a patient taking their medication on site in the RTF that's separate from the existing billing resources for RTFs? Is that the intent of the question?
I know that we're in webinar mode, so I don't know if they can unmute, but it's Leslie.
Oh.
So just saying, and she's trying to follow up in the chat. So just sharing about how in Spokane they have a big deficit in detox facilities, and when they arrive in patient SUD right after having used fentanyl, since they may dose 1 to 3 times per day, and dissolving takes 10 minutes.
Yeah, I mean, this is Sharisa, in terms of the dosing is more complicated because it does take a while to dissolve, but we would not reimburse for, essentially sitting by while someone took their medication. So there wouldn't that wouldn't necessarily, I mean, anybody could sit and watch them while they were dosing. I mean, if the provider were nearby. So I think, I think that's, we would not reimburse. I think there are a lot of different recipes out there. But that the dissolving of the med would not be counted as provider time that could be billable. I do have a question for the gentleman who spoke from Kitsap and Pioneer. Are you seeing in a lot of the folks who come into your withdrawal management setting on opioids that more people than not have additional substance use disorders or problem substance use along with the fentanyl that you're seeing?
This is Brian with Kitsap Recovery Center. A majority of them are definitely polysubstance. And it's normally coupled with methamphetamines.
Yeah, that's exactly what I was going to say. We see a lot of that. And
Yeah.
we also know that a lot of the substance, fentanyl is being cut into methamphetamine.
Yep.
And so unsuspectingly, some of them are going down that path as well.
Yeah.
Well, that's what we see as well.
I mean, one could make the clinical argument, and I'm a family doc and an addiction medicine doc like Dr. Lee, one could make the argument that if someone is on multiple drugs, that probably the place to start, if fentanyl is one of those drugs, rather than withdrawal management, is to get them stable on medication. And if they still are challenged with withdrawal symptoms from that other substance, then withdrawal management makes sense. But to have someone try to enter that without the ability to have the medication support really is challenging, as we've heard. So how do we, similarly with residential treatment, if folks are bailing because their symptoms and they're so miserable, can we sort of rethink how we approach it with a pre-treatment stabilization, get folks comfortable so they can sit and attend in a group, so they are able to think clearly, and have a higher likelihood of success, with which not only benefits the patient client, but I would imagine for treatment providers, it's got to be sort of disheartening and frustrating thinking that are we doing any good? What's wrong, right? And it's not, people aren't trying. It's that this is different. So, I think it's interesting to consider, are there sort of different ways in which we help people down their path of recovery that we might not have needed to think about before?
And this is Keith again at KRC. I would 100% agree with that statement. I think they cannot really truly engage in inpatient treatment if they're not stabilized from the pain that they're experiencing. So they simply won't engage. And so we're not giving them the best opportunity to get recovery. So coming in here, and we will do that sometimes, they know we're not medical, and they'll go see their doctor and get their stuff in. We will observe medication dispensing here so they can come in with it. And then on the flip side, for those, it can be difficult to navigate the system of Medicaid and to get these appointments and to get this stuff set up. So if they're struggling with that, we've set up a system where when they come into detox, we'll get them inducted that first day, so that they, we limit the amount of discomfort that they have, and they can actually effectively engage in their own recovery.
Thanks, Keith. I'm happy to speak to these next two questions. And Dr. Lee, please feel free to weigh in. Another issue we see in a client can't take Suboxone due to things such as an allergy. I think true allergy to Suboxone is rare. I mean, it's been reported, I think now, as so many more people are on it, that people are indeed seeing it. Medicaid does allow for the coverage of Subutex in the instance that people in fact have a documented allergy. I've reviewed a number of those requests myself. So I would say if there are challenges with particular carriers or plans that are making that I suspect that's not the intent of the plan, but sometimes there are multi-layers to processes. I would suggest you reach out to Jessica Blows if someone has benefited from a medication or their provider thinks they would, and that they're not able to get it, please feel free to reach out to us. And just to flow into the next question about naltrexone, you know, the evidence on naltrexone is that it's effective when it's on board in terms of reducing use. I haven't seen any studies, and this is a reminder for myself to look as, is it as effective in the world of fentanyl regular use? It does, you know, obviously reduce overdose death while people are on it. But in terms of end use, right, when someone's on it, because their opiate will not be effective, but it is not shown benefit in terms of mortality reduction. Suboxone and methadone reduced by 50% the risk of death. That's not been shown with naltrexone. Again, maybe it was more effective in the world of heroin, oxycodone, but we've not seen the same benefit from Vivitrol as we have with methadone and buprenorphine, which I know is a challenge for people who really want to not have any opiates in their system, but just fentanyl is just different. And I will leave Jessica to answer the Narcan question.
I apologize. Let me open the chat to see the Narcan question that is there. Actually, if anyone can see the Narcan question, if you just read it out loud for me.
Can you touch on Narcan access?
Absolutely. So the state, our Washington State legislature has passed a law this past year that actually requires all behavioral health agencies to offer naloxone to all individuals who are at risk of overdose. So of course, this population that we're talking about with primary opiate use disorder, or again, using other substances that could put them at risk, would all benefit from these medications. The Washington State Healthcare Authority does have a number of resources available online, both about how to bill for these things with Medicaid patients, uninsured populations, also resources you can have to talk with patients about how to use naloxone. So I will put that in the chat at this time. I will just stop sharing so that way I can pull up that resource and put it in the chat. So I hope that will be helpful. And the Healthcare Authority does have another staff member who is linked on that site, who you can connect with via email directly for one-on-one technical assistance, specifically if you're a behavioral health agency wanting to offer naloxone.
And I can, this is Keith again, I can speak. So we started with the new law being put in place. So we have a part of our intake form. We screen them when they come in. We screen their situation, ask them if they would like it, and then most of them do. We have a supply here that we're given, but what we do is we have a partnership with our. I always talk a lot about partnerships. If we didn't have partnerships, we'd be dead in the water. With our pharmacy, so we can send in. They request that evening. They take the standing order from the state as the prescription, and then they send us that dose, and then they are discharged with their Narcan. For those that maybe go ASA before that evening, they come in the morning and leave by evening, which happens. We have some doses available to give them in case the pharmacy hasn't gotten them to us that evening. But we put into a kind of a situation because we have a pharmacy that delivers to us. So we just get that medication sent over using the standard orders from the pharmacy on a nightly basis.
And then to my colleagues on the call, for whatever reason, as a host and the chat, it looks like I can only send a chat to other hosts. So I'm trying to copy and paste in a link for everyone to check out at Healthcare Authority. And if anyone with better capabilities would be willing to just copy and paste that in somewhere that the guests could see, I would really appreciate it. Thank you.
This is Roel. So one thing I forgot to add, we do prescribe Vivitrol also for our clients. Usually that's like towards the tail end when the client is really serious about it. Our prescriber will meet with the client, and then so she'll initiate getting the first injection in, and then we'll set them up with a clinic to make sure that they can follow through with those injections. On the topic of Narcan, we do discharge our clients with Narcan as well. So we've actually started that process when we first opened up the OUD program.
Yeah. Thank you so much for that. And it looks like, yes, we're actually over on time and we don't have any questions outstanding. So just want to thank everybody for your time. I know you're all busy, and we appreciate you taking the time to go over this information and do some learning. So thank you so much for everything you do, and we'll see you at the next training webinar.